Hello, everyone. Welcome. Can you hear me okay? I'm going to get started. Good morning. Thank you so much for coming today. It's a pleasure to see you here. I'm Catherine McMahon, the program manager at Lupus LA. Hello. Thank you. I've emailed with and talked with a lot of you, so it's really nice to see you here in person today. Thanks so much for coming. We have a really great program today, so we're very excited. We have some excellent doctors here to share with us. And before we get started, I'd like to share a little bit about Lupus LA, and I'd also like to point out our new executive director that we have with us, Susan Bazarski. She's right back here. So you can put a face to the name. Welcome, Susan. We're very excited to have her as part of our team, and you'll be hearing more from her. I know some of you had a chance to meet her out front. So as you probably already know, Lupus LA was created to find the causes of and cure for lupus, while also supporting people living with lupus throughout the greater Los Angeles area. We do have three main areas of focus. The first one is to support and fund medical research. So since we began in 2000, Lupus LA has funded over $10 million towards medical research and local rheumatology fellows. So let's give a round of applause for that. It's very exciting. And our second main area is our patient services. So we offer many great programs, our patient education conferences, which we are at here today. We also have a really great support group program. So in your conference folder, you have a blue flyer which lists all of our support group locations. We also have more copies out on our info table. We would love to see you at a support group. If you haven't come before, they're a really great resource, so please come out. We have 9 adult support groups throughout the greater Los Angeles area. We also have a pediatric support group at Children's Hospital Los Angeles. And for some of the more programs we offer, we can help with doctor referrals. We can help with any questions you may have. We also have an emergency grant program, which can help with up to $500 per year towards medical costs and medical bills, help you get a medication you might not be able to afford. So if you have any questions about any of the programs that we offer or any of the grants, please come see me. I would love to chat with you more about it. And our third main area of focus is promoting awareness and advocacy. So we do an annual trip every year to DC, where we do federal advocacy. We also do trips up to Sacramento, and we meet with our local representatives here in Los Angeles. We have a lot of great events in May for Lupus Awareness Month. We get proclamations from our cities, and we can help assist you if you would like to get a proclamation from your local city as well. And we also have a really great celebrity ambassador program, which helps to promote awareness as well. So that's some of the great programs that we offer at Lupus LA. If you have any questions about any of them, please let me know. And before we get started with Dr. Wallace's presentation, I'd like to go over just a couple things. You do have index cards in your conference folders. So if when you're hearing a presentation today and you have a question, you can write down your question on the index card. We'll collect them at the end of the presentation and go over it then to have a question and answer session. So you can go ahead and write them on there. And if you need any extra copies, we have extra copies as well. So we'll do Q&A after each presentation. I'd also like to take the time to thank our corporate sponsors. So they help allow us to put on these great opportunities. We have GSK here today supporting us, so thank you very much. Give a round of applause and great presentation. And thank all of you for coming. We wouldn't be able to put this on without your help too, so thanks for being here. And before we get started with Dr. Wallace's presentation, I would like to give you a brief introduction on his behalf. I know a lot of you are familiar with him, but I'd like to give some information in case you're new. So Dr. Daniel J. Wallace is an expert rheumatologist. He's a clinical professor here at UCLA. He has a clinical practice at Cedars-Sinai and a private practice where he sees over 2,000 lupus patients, which is actually the largest in the country. His academic efforts include having served as chief of rheumatology at Cedars-Sinai Medical Center, Century City Hospital, and City of Hope Medical Center. He co-directs the Cedars-Sinai Rheumatology Fellowship Program and is also board certified in both internal medicine and rheumatology. His volunteer work has included serving as founder and board member of Lupus LA. He was the 2008 recipient of the Lupus LA's Founder Award, and his efforts have helped raise over $20 million for various rheumatic disease organizations. So we're very fortunate to have an expert rheumatologist like Dr. Wallace with us here today. So please help me in welcoming Dr. Wallace.
Thank you. You're a great agent. So, I missed the meeting last year because I had back surgery, but I'm all cured. So it's been now 2 years. And what I thought I would do is not use any slides I'd ever used before and do a totally different talk. And the outline is that I'm going to talk about 10 bullet points or topics of what's new in lupus in the last year. And none of this really could have been given a year ago. And this will take about 30 minutes. And then we're going to have a 2 to 3 minute stretch period. And I want you to fill out on your 3x5 cards some compelling question that will rivet the audience. And I will go through every single question in the last 30 minutes. And then between Lupus LA and the UCLA catering service, they have a feast for you for lunch before the other two talks. So, the first topic I'm going to talk about is how do we define lupus? Well, the American College of Rheumatology in 1971 defined lupus, and it was a great effort, but it was very, very flawed. And then in 1982, it was revised. And then in 1997, it was revised for the third time. And this is the criteria that many of you have read about. The first 4 criteria are cutaneous, a butterfly rash, sun sensitivity, discoid lesions, and mouth sores. The second 4 criteria are organ system domains, musculoskeletal, pleurisy, pericarditis, kidney, and either seizures or psychosis within the nervous system. And the last 3 criteria are laboratory, an ANA, abnormal blood counts, or certain antibodies. And if one had 4 of the 11 to the exclusion of everything else, this was considered to be for the classification of lupus, but not for the diagnosis of lupus. In other words, you could have lupus without meeting classification, but you need classification in order to be considered for insurance purposes to have lupus, to be in a clinical trial, to be counted in the National Center for Health Statistics using the CPT codes as having lupus. So, an organization known as SLIC, which is a Systemic Lupus International Collaborative Clinics, in 2012 improved on this, and it was a good and bad thing because they made it more sensitive and specific and allowed certain updates in antibodies. And if in the old criteria you could have a kidney biopsy with a low ANA and not meet criteria, so they came up with a classification system, and it was much more scientifically based, but it had flaws and it was a little cumbersome to deal with. So the American College of Rheumatology, in collaboration with the European Rheumatology Group, which has this very quaint name of EULAR, or the European League Against Rheumatism, and basically if you look at the sensitivity and specificity, their new criteria goes up to being 98% sensitive. In other words, it picks up 98% of people with real lupus, and 96% specific. So these criteria are preliminary, they're proposed, they're being vetted, and essentially they are listed here, but I'm not going to go into them in detail because they've really not been finalized. But it's an international effort of several thousand patients from doctors in 30 to 40 different countries. And we will have an international definition for lupus. And if you score 10 points above in 22 domains, which include feeling unwell, which is subjective, objective, which are rashes and swollen joints, abnormal blood tests, and abnormal serologies, one is said to have SLE. Point number 2, is there a role for environment in lupus? Well, there has to be, because if the people with lupus in this room had an identical, and they were female, are female, and have an identical twin sister, the twins' chances of getting lupus are 25%, which means that there's 75% that lupus is due to something else. And so what are environmental factors? So we know that these genes, if there's a certain number of genes that are susceptibility genes for lupus, and by the way, if you want, the Lupus LA will email you my slides. And so you don't have to write this all down, and you can keep the slides. Okay, so all you have to do is just ask my agent, and she'll get it to you. So there are lupus susceptibility genes that, in combination with certain environmental factors, which we'll get to in a minute, we create an abnormal immune response or a dysregulation of the immune system, which promotes inflammation and then damages tissues. So some of the factors that have been associated, a lot of this is from recent work done by the Harvard Nurses Study, where they've looked at thousands of nurses over 50 years and looked at those who developed lupus and looked at exposures. We know that cigarette smoking predisposes towards lupus. How many people here smoke? Nobody. How many people here are lying? Okay, so anyway, we know that tobacco makes it harder to absorb antimalarials, and it can flare the disease. Birth control pills have high estrogen. Contraceptives can predispose towards lupus. There is some evidence that certain heavy metal exposure, arsenic, mercury, cadmium, can do it. Air pollution is associated with worse lupus. Ultraviolet light from the sun, UVA and UVB. Silica, like sandblasters who get sand, or uranium miners, coal miners can get silica. Certain infections, such as Epstein-Barr in particular, and other viruses, predispose towards lupus, and there are isolated reports of people developing lupus with susceptibility factors after certain vaccinations. Talking about the environment, everybody asks, is there a diet for lupus? And for many, many years, I would say, well, nobody's really had any diet for lupus. We say maybe fish or fish oil is good for you, and alfalfa sprouts may be bad for you, but there's been a whole new revolution in understanding lupus, and that is the microbiome. So the microbiome is all the microorganisms in your body, your gut bacteria, any viruses, any funguses, any parasites, any part of your body that is a microbe is considered your microbiome. And we have good bacteria. I mean, things like, yogurt that kill bacteria and are bacteria. And we've evolved with our microbiota. And the problem is that there's no one diet, because everybody with lupus has a different microbiome. So our intestines are home to trillions of microbial cells, with 1,000 or more different types of bacteria in our intestines, 10 times more than the number of host cells, 100 times more microbial genes that commingle with human genes. More than 30% can't even be cultured in the laboratory. And investigators have shown that in psoriasis, in inflammatory bowel disease, such as Crohn's or ulcerative colitis, that they play a major role in activating T cells. So there may be a lupus-associated bacterial makeup. And we know that certain diseases are decreasing with time on the left, and other disorders are increasing on the right. And we think that the microbiome may play a role with this. And the major functions of the microbiome is that they can make vitamins, they can process carbohydrates, digest fatty acids, but they shape the immune system, and they can turn on T cells. And when you turn on T cells, which are white cells that activate the immune system, you can then get certain diseases. So we think that certain gut bacteria activate T cells, which promote autoimmune activity, and this has been demonstrated with at least 2 diseases. Greg Silverman, who is at NYU at the Colton Center, and a doctor at Yale have done some work with lupus. And they have shown that one bacteria called E. gallerium is more common in the microbiome of lupus patients, and that stool from lupus patients represents often a leaky gut syndrome, and these bacteria can then enhance what we call adaptive immunity. And we know that mice with lupus who eat certain diets can't repair DNA right. They hypomethylate. So it's several years away, but in your lifetime, in your lupus lifetime, within the next 5 years, we will be telling you what to eat. And it may be even more effective than steroids or Plaquenil or anything else. So that's real exciting. The other is complement activation. You all know that when you get your blood test, you get complement levels. And complement activation plays a critical role in the immune system in that it clears foreign and damaged tissue. And many patients with lupus experience activation of the classical complement pathway. And historically, you've done C3 and C4. But the problem with C3 and C4, which have been done since the 1960s, is that there's many compounding factors. Sometimes people have normal complements with active disease. Complement can be made and synthesized differently if you have liver or kidney or certain organ disease. And there are complement genes that produce individual variability. So the advance in the last year is the ability to measure complement activation. Rather than measuring C3 and C4, there are labs that now can measure complement activation. And it tells me how inflamed you are more accurately than doing a C3 and C4. We still do C3s and C4s, but we have now availability of something called CB caps, which is the complement activation pathway, and it's sensitive for lupus. It's also seen in some people with active rheumatoid, Sjogren's, scleroderma, and myositis. But if you have erythrocyte C4, in other words, on the red blood cells, C4 complement is activated. It indicates the disease is active, and you can follow its levels to look for improvement. So the bottom line is if complement activation is present, it's associated with lupus activity most of the time. It signifies that you need a stronger anti-inflammatory regimens. And low complements or high complements are much less lupus specific, although they're somewhat useful, and they can be seen in healthy people. Let's go on to compliance. C. Everett Koop was Ronald Reagan's Surgeon General, and he was a real character. He was a Quaker, and he had all these aphorisms. And one of his more famous one was that if a medication prescribed by a caregiver is never taken, it will not work. And so we've noticed in the last few years that non-adherence was a major problem in lupus. If you look at Medicaid data, where you can, and this is a study from Candace Feldman at Harvard, that if you look at Medicaid data, that if you walk into a doctor's office and the doctor says, I'm going to give you hydroxychloroquine or Plaquenil, and that provider writes a prescription, there's a 20% chance it was never filled. There's a 20% chance it wasn't taken as directed. There's a 20% chance that it's still not taken at the next visit. And there's a 60% chance that the provider doesn't know anything about this. And non-adherence is, according to Candace, is associated with many more emergency room visits and hospitalizations. And now there have been 11 systemic reviews in the literature saying that the non-adherent lupus population is 43 to 75%, and that a third discontinue treatment after 5 years. So, and this is not just in U.S., Murray Urowitz has shown it in Canada as well. It is associated with people with a lower level of educational and socioeconomic attainment, but I think there's an epidemic of it here on the West Side as well. And the only thing I can say is that the same lab that does complement activation that I just mentioned, it's called Exogen or Revise, also came up with a brilliant test in the last year. I can measure your hydroxychloroquine blood levels and see if you're taking it. So you're going to be busted if you claim you're taking it and your level is 0. So we're getting smarter. Or if you're taking it once a week or intermittently or the day before your appointment. So we are not to assume that patients are adherent. You need to closely monitor response. And it's really our fault that you're not adherent because we're not communicating and educating right. So that's our job. So there's lots of strategies that have been published, and I'm not going to go into that in the interest of time, but we're working on ways of sorting this all out. All right, patient-reported outcomes. Well, for the last few clinical trials that have been published, well, let me just go back. In 2005, the FDA put out a lupus guidance documents to get a drug to market. And it had a lot of problems, and it was revised in 2010. And part of the guidance document was something called physician-reported outcomes, which was on a scale of 3, the physician would put in a tick mark how they felt you were doing. But that was sort of like the Me Too movement. It was very, very arrogant because nowhere in this document in 2005 was asking the patient how they feel. Okay? I mean, you think that's important? Of course it is. So in 2010, when the Obama administration revised this document, they not only put in patient-reported outcomes as something that every pharmaceutical company has to include in a trial, but they went one step further. They said if you could show in a statistically correct fashion that the patient feels better, you can actually get the drug to market if nothing else improves, which is really quite revolutionary. So everybody started to freak out and said, okay, we got to work on patient-reported outcomes. So what did we have in 2005? We had we had something called the SF-36 and health-related quality of life, and these were not lupus specific. The questions would be, are you more tired than you were in the last week? Do you have trouble getting in and out of a car in the last week? But it could be due to your broken leg. It could be due to your fibromyalgia. You could be more anxious, depressed because of your steroids. So this was the quality of life marker. So a group of people have, in the last 10 years, all over the world, in the Netherlands, in Singapore, in the UK, and more recently in the United States, have developed lupus-specific markers. They changed the question. It says, due to your lupus in the last week, are you more depressed? Due to your lupus in the last week, is it harder to get on and off a toilet seat? So the 6 had been validated, but the problem is it's not for international use. It's not cross-culturally validated. You know, there's so much diversity in Southern California that if I were to ask this question to one ethnic group, they would answer completely differently than another ethnic group. You don't want to lose face. You don't want to say, I don't feel well. So ultimately, there's a rheumatologist at the FDA and the NIH named Jim Witter. And he is a board-certified rheumatologist who developed a computerized system that you do on your laptop or on your smartphone, and it's called the PROMIS system. And what it does is, first of all, you could ask the question at 10 in the morning, and it's going to be different at 10 in the evening. So he randomly, in the drug studies that he's supervising, he randomly asks you questions at different times of the day and says, are you tired due to your lupus? And if you say yes, then the screen comes on with 3 other questions that account for some of the cross-cultural issues. And then it's 3 or 4 questions that you answer yes or no to, or A, B, or C. The whole thing takes less than 3 minutes. And he has now put together an inventory of several 100,000 responses with the help of Patty Katz, who's at UC San Francisco. And they have now published this. This is now being used in rheumatoid arthritis and scleroderma trials. And in the next 2 or 3 years, it'll be the mechanism of choice. And it's adaptive, elastic design. It will change as the environment changes. If we have more earthquakes, if we have a new president, if we have new things going on, the answers will actually be different from getting better or worse. So this is an adaptive, elastic design that has been shown to be very specific, and it's now, in the next year or 2, will be introduced into lupus clinical trials. All right, well, after a long time, we finally have some positive lupus trials. There is a drug called baricitinib, which some of you in this room may have been on. It's a pill that just got approved for rheumatoid arthritis, and it appears to help lupus, and it is going into a phase 3 trial. There is another one of the sponsors here, Rennie, has a drug called voclosporin, which is an improved version 3.0 of some of the lupus nephritis drugs. It appears to be very, very dramatic in improving lupus kidney disease. And this is now being studied in a phase 3 trial. I'm not going to talk about this because their phase 3 trial turned out to be negative last week, and I already made up the slides. And then there's another drug called ustekinumab, which is known as Stelara, which is a drug that has been on the market for 5 years for psoriasis, and it's also approved for Crohn's disease. It's a T-cell blocker, and it has had a favorable lupus trial in phase 2, and it's going into phase 3. The problem was that the dose in psoriasis was only 1/3 of what you need to lupus. So we're using it in a lupus dose, and we are actually doing this at our center. So if anybody is interested in a phase 3 trial with a drug that's very safe because it's been on the market for 5 years with no side effects, let us know. All right, Lumos. Lumos is the Lupus Method operating system. We have never had a good way of measuring improvement in lupus clinical trials. In fact, since Eisenhower was president, we've only had belimumab approved in 2011. Steroids and antimalarials and aspirin were approved for lupus in the 1950s. And when I started my practice a long time ago, last century, we had steroids, methotrexate, Imuran, and Cytoxan. We still have them. And we really haven't introduced too many new things. The only new ones that have been introduced is mycophenolate or leflunomide, but they're not approved for lupus, and Benlysta. But there are a lot of other drugs that are used for rheumatoid arthritis and vasculitis that work for lupus, but didn't make the trial design of the FDA that are listed there that I could talk about. And in fact, using the 2010 FDA, 2005 and 2010 FDA guidance document, 20 drugs have had negative results. So this is really, really sad, but hopefully with our new trial design. So the problem why these trials failed was that the drug either didn't work or it wasn't safe, or the trial design was flawed, or the primary outcome measure was wrong. Trials are notoriously badly implemented, and especially in other parts of the world. People are allowed to take medicines during the trial that are compounding or artificially taking steroids in ways that they shouldn't. But most importantly, the domains of lupus assessment, which is the primary outcome measures for these trials, the SLEDAI and BILAG, were used, and they are heavily flawed. So when you do a lupus trial, you measure disease activity, you measure damage, which just means irreversible changes, you measure quality of life, you measure flares, you measure things in specific organs, and you measure a composite which takes all these things and puts them together. And these are highly flawed. So the Lupus Research Alliance, which is where this organization, Lupus LA, gives some of our research money to, it's a collaboration with the LRA and industry, has proposed a new outcome measures where what they are doing is taking all the completed lupus clinical trials, those that were successful and those that failed, and based on CRFs or clinical report forms, there's like 200 pieces of information that are collected, from blood pressure to how the patient feels, to pulse, to what medicines are on, to what their hemoglobin is, and what their creatinine is, and whether they have protein in the urine. And using that, they're devising a metric called LUMOS, which will accurately measure lupus outcomes. And the goal here is to accelerate the approval process, and the FDA has been very supportive of this. How many people here have taken hydroxychloroquine or Plaquenil at some point? How many people have never taken it? All right, so just a handful. Maybe you're probably a guest of a lupus patient. But we've learned some interesting things. There's the people with lupus get scared about, the doctors and the patients get scared about their eyes. So we have some new information. We know that hydroxychloroquine, no matter what flavor of lupus you have, improves damage. In other words, it decreases irreversibility. It decreases irreversibility. We know that if you take antimalarials in the first 5 years, people live longer, have more damage, and are on less corticosteroids. We know that if you take hydroxychloroquine, there are fewer disease flares. And this is using, our drug levels. We know that if you have more hydroxychloroquine in your blood, you do better. So the American Academy of Ophthalmologic Surgeons, headed by Dr. Marmer at Stanford, whose father, Judd Marmer, founded the Department of Psychiatry here at UCLA in the 50s, And he headed a committee which put together the recommendations for hydroxychloroquine retinopathy screening based on literally thousands of articles written throughout the world. So here's the bottom line with your Plaquenil. First of all, the recommended dose is to take no more than 5 milligrams per kilogram. So if you're 150 pounds, you're 70 kilograms, so your ideal dose would be 350 milligrams, okay? So if you do not exceed the recommended doses, the chances of you having any eye damage at 5 years is less than 1%. At 10 years, it's less than 2%. After 20 years, it goes way up. So the bottom line is you have a free ride for up to 10 years. And then after that, you need to be checked every 3 to 6 months. The exam should consist of looking at your fundus, and for the first 5 years, you can go 2, 3, 4 years without being checked. But we have a new method now of screening for eye toxicity. It's called the OCT, or the SDOCT, which is the spectral domain optical coherence tomography. It's a CT scan of the retina. And many people have stopped Plaquenil in the last 10 years, 20 years, because their eye doctor said, well, you may have this, you may have that. But they didn't have anything objective. Now we have an objective CT scan that's done in the retina specialist office. It takes about 3 minutes to do, and it will tell you whether there is any damage to the retina. And if you see the damage, it is often not reversible, but if it's but it's not going to cause any eye changes in 90% of the cases. So we need to educate the patients. All the retina doctors know how to do this. Lastly, let me talk about the future. Where are we going with new clinical trials? There are clinical trials of agents that block T cells, block B cells, inhibit complement activation, block a sort of a cell hormone called a cytokine or interleukins, interferons, deal with the innate immune system, which is sort of our prehistoric immune system, that promote tolerance or prevent cell surface receptors from being activated. There are probably about 30 clinical trials now in lupus. Almost all of them fall in one of these categories. The new advance is the introduction of subcutaneous belimumab in the last year so that you don't have to get it IV every month. And it works as well as the IV, but there's still a lot of people that we like to give the IV to because they have a lot of other issues going on. And as a result of subcu belimumab, the number of people in the United States with lupus on this drug has increased from 20,000 to 50,000 in the last year. And so a lot more people are having access to this drug, which is a very safe and effective drug in lupus. For lupus in the kidneys, we used to just use cyclophosphamide or mycophenolate, but the new mantra is to pretend we're oncologists and don't just give one drug at a time, but 3 drugs at a time, where we load the patient with steroids and we use a drug called tacrolimus with mycophenolate and or cyclophosphamide. And we are having 50% fewer patients with lupus going on dialysis as a result of combination therapies. Other things that are being looked at are interferon inhibitors, and that included the drug that I said didn't meet its endpoint, but there are others. Drugs that block a cytokine known as interleukin-6, but a lot of the excitement is with oral agents that aren't shots or IVs, and such as baricitinib that I talked to you about. The National Institute of Health is working on has just given a $5 million grant, and Cedars is one of the recipients, to look at mTOR inhibitors, which are pills that blocks cell surface receptors. And there's also a cell called a plasma cell, which makes antibodies, and several drugs that are on the market for myeloma, which is a plasma cell disease in lower doses, may be helpful for lupus. But since we're in West Los Angeles, we have to talk about stem cell. So there is a mesenchymal stem cell study that we will be part of that will start in about 2 or 3 months, headed by Gary Gilkison at the Medical University of South Carolina. And this is not the type where a touchy-feely a person who's a nurse practitioner opens up a stem cell center and charges $10,000 because they give nice food and free parking. But this is a real stem cell study. It's heavy-duty stuff, and it will be available for about 10 of our patients who qualify in the next 2 to 3 months. So in conclusion, and by the way, if you want to learn more about some of the clinical trials we're doing, we have a table in the back, and you can talk to Jennifer or Carla. And lupus is characterized by a shortened life expectancy with a significant increase in morbidity and mortality. We have to get you to be adherent to take the drug, and we can now measure activity better, and you can tell us how you're doing. And this is all evolving, and there's going to be lots of changes. So thank you very much for that part. And we're going to have a 3-minute stretch, and our staff will collect your 3x5 cards. Two-minute warning. Bathrooms over there. 1-minute warning. I'm going to go real fast. It looks like we have 50 questions, but I promise you I will answer them all by 12:10. All right, are we ready? By the way, if you use up the back side, I don't answer it. I only answer questions that are on the first side of the card. Sorry. When in remission does your ANA go negative? Can it disappear with your blood results? Rarely, but drugs such as steroids and immunosuppressants can make an A negative. Does lupus cause skin discoloration? Yes. Do multivitamins exacerbate lupus symptoms? The vitamins, no, but sometimes the preservatives in it, yes. Is there such as a inflammatory lupus diet or lectins bad? What about the Grundy claims? Are nightshade vegetables bad? We don't know, but we'll know in the next 5 years, before you're just around the time you're cured. Will Benlysta become available in a pill form? No. Will we have to do the IV treatment? No, you can do the shot form. Whooping cough vaccination, is it safe? It's a live vaccine. So if you're just on Plaquenil, it's probably okay, but if you're on any immune suppressive, it may flare the disease. Stem cell therapy, is it effective? We don't know. We're going to find out. Would I recommend probiotics for a lupus patient? Try it. It's harmless. If it works, great. If it doesn't work, too bad. Why is there not copay assistance available for brand Plaquenil? Good question. There is no brand Plaquenil anymore. The company that made brand name Plaquenil sold it to a generic company. So there's no difference. And they don't really make it with the same rigor. If you really want the traditional 1990s brand name Plaquenil, get it from a Canadian pharmacy or from France. Okay? There's a few people that are sensitive to the generic. Ustekinumab. I'm on Stelara, but at the dose for psoriatic arthritis, would I recommend talking to my doctor about increase? Well, the dose that's used for psoriasis, if Stelara is 45 or 90, the dose that works in lupus is 180. So you'd have to, and it's only available as part of a clinical trial. So if your doctor can get you sneak in extra samples, it's about the only way you can get it. C. diff and lupus. What about bacterial infections? It's a major problem, especially in people on immune suppressive drugs. And so that's the issue with everything from belimumab to Cellcept to Cytoxan to methotrexate. There are increased infections. So the only hydroxychloroquine or Plaquenil does not increase infections. And you can usually get by with low-dose steroids. What's the right time to find a new lupus doctor? Whenever you're not happy with the old one. Does Humira work for lupus? Humira is a drug for rheumatoid arthritis. And Humira, if there are some people who have rupus, which is a little rheumatoid with a little lupus, and there are some lupus patients that do well in Humira, but by and large, they don't. How does one achieve remission? I was diagnosed in 1994. Well, remission's a very problematic term. There's clinical remission, which means I feel fine. There's laboratory remission, which is all your blood tests are normal. What we really want is we now have a score called an LL-DAS score, which means low-level lupus disease activity score. And that's if you're off steroids, if you're off immune suppressives, if you have a SLEDAI score of 2 or less, in other words, if you're SED-rate and CRP. So remission is achieved in most lupus patients who do not have organ involvement, that's heart, lung, kidney, or liver. Is it common for lupus to go into remission during pregnancy? And yes, in the second and third trimester. It often gets worse in the first trimester. But the placenta makes cortisone, the baby's adrenal gland makes cortisone, and your adrenal gland is stressed, so you make a lot of cortisone. Do you feel that growing up in the city of LA in the 60s and 70s smog era could be a cause for developing lupus? Well, I'm older than you. I remember growing up in LA in the 50s where we had incinerators. But I think there are some loose reports of air pollution causing more lupus, but they're not from LA. They're from New England, where they had more in other words, a different type of pollution that's nitrogenous versus sulfurous. Thank you so much for your presentation. When I discovered my wife, basically, the bottom line of this long question is, what about CBD? In other words, medical marijuana, CBD cannabis oil. Problem is, if you feel better with it, it's fine. It's not anti-inflammatory, but it may help pain. But it's not regulated, so every batch is different. So you may be good one time, but next time you go to MedMen, it may not work. Will detoxing for less than 5 days while taking your meds affect your... In other words, can you do a detox? My problem with detox is if you take enemas, a lot of people who've been on prednisone have very thin bowel lining, and you can actually perforate your intestine with a well-meaning detox. What is the recommended treatment for lupus patients with coronary heart disease? It's to see a cardiologist because there's 20 causes of coronary heart disease. Some are due to coronary arteritis. Some are due to microvascular angina. Some are due to smoking. Some are due to hypertension. Some are due to steroids. So there's 20 causes. So I can't really answer that. I don't have enough information. What is the potential life expectancy of a patient with kidney disease, heart disease, lung disease, and scleroderma? It's called a full house. Basically, when I started my practice, half with lupus and organ disease were dead in 15 years. Now it's 30 years. So things have improved. 20% with lupus in their kidney are on dialysis in 5 years, and probably 40% in 10 years. I mentioned several diseases in relation to lupus. Are they related and based on the disorder of the gut, such as inflammatory bowel disease or Crohn's? 20% of people with one autoimmune disease have a second autoimmune disease. So if you have lupus, you could have Hashimoto's thyroiditis, you could have inflammatory bowel. And so there is some immune dysfunction. So we do have people with multiple autoimmune conditions. I've had 6 Cytoxin IV treatments that worked, and I'm only on Plaquenil. How long do you think I will be in remission? I think that maybe there's a 1/3 chance that it will never come back, and a 1/3 chance that it'll come back at some point in the future, and there's a 1/3 chance that you will go into kidney failure in the next 10 years. I was recently diagnosed with a meningioma. Could this be associated with lupus? No. What is the appropriate jobs for lupus? Number one, those that are indoors. Any tuna fishermen in the audience, or farmers, or construction workers? I think that also jobs that allow you to pace yourself. How many people here with lupus are tired? How many people here with lupus are never tired? Okay, so my mantra is that lupus patients are not disabled. Lupus patients are differently abled. You're smart. You can do things. I want you to work. And it's going to be hard to get disability from me. To that end, I want you to get a job where you can pace yourself, where you have work periods associated with rest periods. You work for a couple hours, you rest for 10 minutes, you work for a couple hours, you take a lunch break. If you take 4 or 5 breaks during the day, you can get as much done as anybody else. If you're a lawyer or a doctor or an accountant or a high-level professional, you can often just work out of your house and set your own hours because there's administrative things you can do. The problem is if you have to punch in a 9-to-5 job, that's what makes it harder to work with lupus. But you could still be a realtor, a travel agent. There's lots of things that people who aren't college graduates, who are very smart and want to work, can do and make more money than some of the others. What do I think of LDN, low-dose naltrexone? Well, LDN was a drug introduced, naltrexone was introduced 30, 40 years ago to treat heroin and cocaine detox. But in very low doses, it helps fibromyalgia and myofascial pain. So if you have lupus with fibromyalgia, it might help. It's safe. It has to be compounded. When does Benlysta work in terms of symptoms? In 3 to 6 months. Why is lupus more prevalent in people of certain ethnicities? Why is it in 1 in 250 African American women? Why is it in 1 in 70 Sioux Indians? Why is it in 1 in 1,000 white females? The answer is genetics, and in the environment. Are you taking new patients? Yes. My office is taking new patients. Can Plaquenil cause hair loss? Actually, usually causes hair growth. Plaquenil is very effective for me, but hydroxychloroquine doesn't work well, so get it from Canada. I can't read this. I'm sorry. Your cursive does not meet the cut. Do you know anything about the use of worms for the microbiome? Well, some people are actually giving fecal transplants to help certain, like chronic C. diff. So, yeah, it's a lot of things are are going on. All right, let's see. Are people born with lupus? There's something called neonatal lupus if their mothers are SSA antibody positive. And usually goes away because the baby doesn't make the antibody. You can get lupus as young as 2 years old, but that's the answer. Why do so many lupus patients have fibromyalgia? Well, it's about 25%. Because drugs given for lupus cause fibromyalgia, like steroids. Lupus patients have difficulty coping, and it's part of their psychosocial stress reactions. So now we're on the last 5 cards, and these are the people who are very verbose. Leaky gut syndrome, we think it's the microbiome. Plaquenil takes about 3 months to work. How would stem cell therapy help lupus? By giving you basically a new bone marrow, by giving you a new system that makes drugs. You woke up in the middle of the night, confused, unaware, and you were frightened. How concerned should you be? It depends. Basically, there is, lupus can cause, is associated with lupus fog, and there is there is neurologic workups that can look for that. Does lupus cause mucus strings in the urine? No. How concerned should I be if I have lupus and Sjogren's and it's not being treated? Yes, I would be concerned. What's the likelihood of immediate family members to be diagnosed with lupus? And the answer is that if a woman with lupus has a child who's a daughter, 10% chance, son, 2% chance, 20% chance she will have a full first-degree relative with an autoimmune disease, most commonly Hashimoto's thyroiditis. I had a bad flare with brain fog. And is it okay to take Tylenol? Well, Tylenol won't work. If you have brain fog, you should talk to your doctor. There's many causes of brain fog. Medication can cause brain fog. If you're diabetic, you could have brain fog. If you're hypertensive, you could have brain fog. If you're depressed and anxious, you could have brain fog. If you're anorexic or bipolar, you could have brain fog. So if you have fibromyalgia, you can have brain fog. So it's a loaded question. So you need to see your doctor, have a complete workup, and certain neurologic testing may or not needed. I've had my lymph nodes removed and swollen and biopsied. Well, there is a syndrome associated with lupus called Kikuchi syndrome, which is where you have huge swollen glands, and it's seen in about 5% with lupus associated with fevers. And it responds to short courses of steroids, and it's usually very reversible, but sometimes in early lupus, it's how the disease is diagnosed. Vaccinations, which are good, which are bad. Flu's fine, it's a kill vaccine. Pneumonia is fine, it's a kill vaccine. Shingrix is a live vaccine, but it's good, it's fine, but if you're on an immune suppressive, you have to stop it a month before and a month after the vaccination. Okay, so except for the person whose handwriting I can't read, I've done all of them. And right now we have about 10 minutes. So anybody want to, we don't have microphones here. Okay, there's only one rule. Don't talk about yourself. Ask the question so that the audience will learn something from your question. So we're going to go around here. Go ahead.
I couldn't get rid of it.
What's the question?
I said, I had a flare-up, and it lasted 7 days,
Right.
the longest I ever had. And I don't know what kind of pain medicine I should be taking, because when the flare came, my body ached, I was tired, and I couldn't think straight.
Well, again, I don't want to answer questions about your case because flares are different for everybody.
I'm talking about what is the best
if
medication
the flare is
for pain.
if the flare is from inflammation, it can be associated with pain. And there's many different types of organs that can cause the flare, and each organ is treated differently. And I know lupus is generally not painful. The percentage of lupus patients that are on opiates in the United States is only 5%. And pain centers rarely see lupus patients. So the treatment for lupus pain is usually to treat inflammation. But if it's musculoskeletal, it's from fibromyalgia, then that's a little different. Other questions? Yes? If the whooping, often people have children and grandchildren have been told to have vaccinations, and if you're just on Plaquenil and nothing else or nothing, it's fine. Okay, yes. IVIG is used for people with low platelets, for people with autoimmune hemolytic anemia, and it is used for a condition called CIDP, which is chronic inflammatory demyelinating polyneuropathy. Yes. Oh, in other words, if you fall on your discoid lesion, would the discoid lesion take longer to heal? Yes, and it could get infected, but you just have to be very careful. Yes?
Towards the end of your talk, I couldn't write fast enough. Plaquenil does promote hair growth or does not?
It does.
It does. Okay.
In the right places. Yes. Plasmapheresis or apheresis. Apheresis is where you filter the blood. It is used for CIDP. It is used for hyperviscosity syndrome. It is used for alveolar hemorrhage. It is used for cryoglobulinemia. And it is rarely used for severe vasculitis or central nervous system lupus. Yes?
What do you replace echinacea with?
Well, echinacea can actually flare lupus, and any herb, spice, nuts, or berries that don't harm you are fine. Yes. Plaquenil causes bruising, aspirin causes bruising, Advil or Aleve causes bruising, and steroids cause bruising. And lupus itself only causes bruising if the platelets are below 30,000. How do I what? How do I help hair loss? Oh, okay. Well, the problem with hair loss is that hair falls out, hair thins with inflammation, and it doesn't fall out for months later. And it's often, once you're better, the last thing to improve. And regrowth of hair, lupus hair is often a fine baby's downy hair. In the back, with Adam. Go ahead.
Is there any connection between melanoma and lupus?
No. That go there. Yes. Yes. Yeah. First of all, people with epilepsy can get lupus and it has nothing to do with it. Certain drugs that are given in lupus patients can lower seizure thresholds. And lupus, if it affects the brain, can acutely cause seizures. And if the brain heals with the scar, you can have a scar focus causing epilepsy. Over there, yes. Yes.
Is there a dose range for?
Yeah. Yes, you can take. Problem is, right now there's only a 200 milligram tablet. There is a company that's applied to the FDA to make a 300 milligram tablet. And if you have mucho dinero or work at Children's Hospital, you can get liquid Plaquenil and then do whatever dose you want. What? Or I don't know if is there liquid Plaquenil in Canada? There may be. I don't know. Okay, over there. You can ask Dr. Abloff. She's going to give a talk on hair at 1 o'clock. and she does everything from PRP injections to Rogaine to steroid injections. Yes. It's a good question. For about 2 weeks, from week 2 to week 6 postpartum, when you don't have a placenta and you don't have a baby and your adrenal gland shrivels up, about 20 to 30% can have a transient postpartum flare, and it's usually managed with a short course of anti-inflammatories, such as like a Medrol dose pack or something. In the back. Prednisone, immune suppressive therapies, Celsep, methotrexate. Yes. Okay, there's a lady named Betty Diamond who's at the Long Island Jewish North Shore Hospital in Long Island, and she has done some work with cannabis derivatives in lupus. She's doing a study right now. She's completed one for dermatomyositis. It was actually positive, and it appears that some of the cannabinoid derivatives may have an anti-inflammatory component, but I would go on PubMed and try to locate some of their literature. Yes. Yeah. Yes, you. Listen to your doctor and pay attention to what advice they give. Talk to the people at Lupus LA. We have people who can assist you and triage you to, it's a big decision to take medicine. But, and it's a very personal one. But you have to come to terms and see what the pros and cons are. Yes? If the pain is from inflammation, it's anti-inflammatory. If the pain is non-inflammatory pain, there's Cymbalta, Lyrica, low-dose naltrexone, some drugs like quetiapine, which are the atypicals, Flexeril, Robaxin. There's lots of tramadol. There's lots of things that we use. Yes, ma'am. There are ongoing clinical trials in Sjogren's syndrome, but there's only 2 or 3 going on in the entire United States. Most of them are in Europe, and none of them are really very good. Yes. Well, there's the non-medication, which is everything from melatonin, which is safe, to St. John's wort, to Calms Forte. I don't have any problem with occasional use of the traditional sleep medicines. If the patient snores, we might want to do a sleep apnea workup, because that could be part of the problem. They might have a comorbidity, such as in their heart or lungs, it's making them hard to sleep. But anxiolytic approaches, treatment, deep breathing, biofeedback, cognitive behavioral therapy, there's lots of things that you can do. Yes? No, it doesn't. Yes? Pseudoobstruction is more often seen with scleroderma lupus overlaps. Yes? Well, Up to Date is very good, and there is a website called Up to Date. All the lupus advocacy groups, and if you just Google lupus, but there's many of them. But Lupus LA has actually hyperlinks to other lupus resources, everything from the Arthritis Foundation to Lupus Research Institute. Yes? Not necessarily. It's usually not addictive. Only 10% have an addiction problem with it. Yes. Yes, there's something called lupus urticaria. It's seen in about 5%. And it's, you go to your allergist or dermatologist, and I would actually talk to Dr. Abwab about it. She can address it this afternoon. Yes. Yes, it is. Yes, it is safe. All right, 2 more minutes. Go ahead. It's people who don't have lupus. It's been reported in mostly the live vaccines, which are some of the travel medicines, typhoid, pertussis, and it's very uncommon. There's probably maybe 50 reports in the world's literature, but it has been shown to do this. Yes. I think if you keep with the lupus websites, you could follow Greg Silverman, and his name is on the slide, or the gentleman at Yale, and Google them, and they'll have updates with their research. Mark Pimentel at Cedars-Sinai is a gastroenterologist who's done a lot of work with lupus and diet. He was the inventor of Xifaxan, which is a major drug for small intestinal bacterial overgrowth. Who hasn't asked a question who wants to ask one? Go ahead. Atrovent nasal spray, Atrovent. No, but it's inexpensive, generic, easily available by prescription. Yes. Yes. No. No, doesn't make a difference. Last question. Greg Silverman at NYU is probably the leading lupus diet investigator in the United States. Mark Pimentel at Cedars is doing a lot of work with bacterial overgrowth and the microbiome at Cedars-Sinai. Okay, well, I will turn it over to my agent here. Thank you.
Thank you so much, Dr. Wallace. That was really great. We appreciate it. Thanks, everybody. Okay, we're going to break for lunch now. It's just right out here to your left. We'll begin the program again at 1:10. So we'll see you then. Enjoy your lunch.